Picture this. You're sitting in that crinkly paper gown waiting for your yearly lab results. Same healthy-ish lifestyle, same general habits, maybe even eating better than you were 5 years ago. Then your doctor walks in with that look on their face and starts talking about statins and prediabetes like you've been living on donuts and Netflix for the past decade. What the hell? If this sounds familiar, you're not alone, and you're definitely not crazy. You just got blindsided by perimenopause and nobody bothered to give you the memo. I'm Megan, and this is Mornings with Megan. We're here to talk about what's actually happening in your body during perimenopause, no BS. Today, we're diving into metabolic health and why perimenopause is the metabolic inflection point that nobody warned you about. Here's something that might make you angry. In your 20s and 30s, you had less heart disease rates than men. Estrogen was protecting you. Your lipids looked good, your blood pressure was fine, your glucose was stable. And because everything looked fine, many of you probably stopped seeing your doctor regularly after you had your last child, if you had children, or sometimes in your late 30s. There wasn't a reason to go, right? Everything looked good. Then you hit your 40s and suddenly, seemingly out of nowhere, you have high lipids, high blood pressure, high glucose. Your doctor acts like you've been doing something wrong, but you haven't changed anything. What happened? Women catch up to men in heart disease risk by the end of menopause. We end with the same lifetime rate of cardiovascular disease as men. We just get there differently. And we get there faster once perimenopause starts. Here's what nobody's preparing you for. Perimenopause is very similar to pregnancy. It's a physiological stressor. If you haven't prepped for it, meaning if you aren't metabolically well managed before perimenopause, things can go sideways fast. Your body wasn't prepared for the stressor, so it struggles more. And life stage contributes to this. Perimenopause often coincides with older children, career advancement, aging parents, and more responsibilities in general. No one gave you a memo in your early 30s saying, let's set you up for success. So by your 40s, you're playing catch up. Dr. Eve Henry, a physician who specializes in women's cardiovascular health, calls ages 40 to 48 a period of medical vulnerability for women. This is when everything can shift, and most women have no idea it's coming. Let me start with something that might blow your mind. Your metabolism doesn't actually slow down. Your resting metabolic rate stays pretty much the same until your early 60s. So, what's really happening? Hormones, all of them having a complete meltdown. During perimenopause, estrogen and progesterone don't just drop, they fluctuate very wildly. And these hormones affect every system in your body, particularly your liver. Your liver is a key player here. It clears and makes cholesterol. When estrogen is high, it clears more cholesterol and makes less. When estrogen drops, the receptors that help clear cholesterol decrease in number. So your liver starts making more cholesterol and clearing less. Your liver also drives changes with glucose. With less estrogen, your liver produces more glucose when it's stimulated and is slower to clear insulin from your bloodstream. At the same time, several other things are happening. Your insulin sensitivity decreases. Your cells become resistant to insulin signaling. Your ability to remove and use fat for energy decreases, but your rate of fat storage stays the same. I know, it's very cruel. So you're storing fat at the same rate, but burning it more slowly. You start storing fat in a more inflammatory way. Visceral fat, the dangerous fat around your organs, can increase 2 to 3 times before menopause with no lifestyle changes. Your total body inflammation also increases. This creates a cascading effect. Inflammation drives insulin resistance, which drives more inflammation, which affects your lipid metabolism, which increases cardiovascular disease risk. It's like we're set up for failure. All the tricks that work to lose weight in your 20s and 30s stop working in perimenopause. There's this incredible study called the SWAN study. It followed women for 18 years through perimenopause transition. The results showed exactly this pattern. Body composition changes, insulin resistance climbing, inflammation increasing, and hot flashes correlating with insulin resistance. Women catch up to men in cardiovascular disease risk incredibly quickly after menopause. And cardiovascular disease, heart disease, stroke, metabolic disease, is the number one killer of women in the United States. When you look at the top 14 causes of death in women, all but accidents are directly or indirectly related to metabolic health. Here's a statistic that puts that in perspective. You are 13 times more likely to die of metabolic disease than breast cancer. And here's what makes that even more urgent: about one third of first heart attacks result in death. Heart disease in women is often a silent disease. You don't get the classic chest crushing pain that men get. Women are more likely to experience nausea, upset stomach, and arm pain, symptoms that get them dismissed as indigestion and anxiety. Unless you're tracking your labs, you may have no idea what's building up in your arteries. This is why knowing your metrics early and often is so critical. We need to start seeing the pattern shift before it becomes disease. Hemoglobin A1C, for instance, is personalized to you, especially if you can't track it when you're earlier in the process and healthier. Then you know what your optimal baseline is, not just what the normal range says. And if you really want to understand your patterns, a continuous glucose monitor can give you even more precise data about how your body responds to food, stress, and sleep. These are the metabolic markers that tell me the most about what's actually happening in your body. Number one, fasting insulin, gold standard. Your sweet spot under 10. Most standard lab work doesn't even include a fasting insulin, but this is the first marker to show problems years before your glucose becomes elevated. When fasting insulin is elevated, your cells are resisting insulin signals. This creates that blood sugar roller coaster that has you reaching for emergency snacks all day long. You can have perfectly normal fasting glucose and still have insulin working overtime behind the scenes. This is the test you need to request specifically. It's worth the pushback from your doctor. Test number two, hemoglobin A1C. This measures your average blood sugar over the past 3 months. Generally, you are looking for a range between 4.5 and 5.5, depending on your patterns. Standard ranges go up to 5.7, but for sustained mental clarity and stable energy, you want to be lower than that range. Now, here's the nuance: hemoglobin A1C is based on red blood cell turnover, typically about 90 to 120 days. If your red blood cells turn over faster or slower than average, it can skew the results. This is why you need to look at the pattern across your hemoglobin A1C, fasting glucose, and fasting insulin together. Number three, triglycerides, the early warning sign. Triglycerides are an early warning sign of insulin resistance. Less than 50, beautiful. Between 50 and 100, we need to watch your other metrics closely. Over 100, we've got something that we really need to focus on. There can be genetic factors that affect triglycerides, but for most women, elevated triglycerides signal that your body is struggling with insulin sensitivity. The backup, the triglyceride HDL ratio. If you absolutely cannot get a fasting insulin ordered, you can use your triglyceride HDL ratio as a proxy marker for fasting insulin. Take your triglycerides, divide by HDL. Your goal is 1 or less. This ratio is validated for European and Asian populations. It's less reliable in African American populations. So if you're African American, really push for that fasting insulin test. But let me be clear, fasting insulin is the gold standard here. Triglyceride HDL ratio is the backup plan when you can't get the test that you actually need. Now let's talk about cholesterol. Your total cholesterol numbers mean almost nothing here. Let me give you an analogy. Think of LDL and HDL as transport trucks. LDL is the delivery truck. It brings cholesterol to damaged arteries and blood vessels for repairs. Your body needs cholesterol. It's essential for hormone production, cell membranes, and repairing damage. HDL is the recycling truck. Once the repairs are made, the HDL takes leftover cholesterol back to the liver to be recycled or eliminated. Higher HDL is protective. You've got more trucks picking up excess cholesterol and clearing it out. So, what causes plaque and heart attacks? Dr. Eve Henry has a brilliant way of explaining this. She describes LDL particles like tiny bouncing balls in your bloodstream. Think of blood pressure like water pressure in a hose. The more pressure, the more likely those balls hit the artery wall with force and get stuck. When a small, dense LDL particle gets into the artery wall and becomes oxidized and inflamed, Dr. Henry describes it like this: thinking of plaque like a pimple. The oxidized LDL is the schmutz or the gunk. Your immune system sees this damage and paves over the schmutz with cement to contain it. That's the plaque. So soft plaque is just schmutz and putz. Hard plaque is paved over schmutz. A heart attack happens when the pimple explodes. The immune system sees the schmutz all over and reacts like it's an emergency, and it forms a clot. The fuss about the explosion combined with the inflammation and the blockage from the clot is what causes the heart attack. The tiniest vessels are the easiest to block, in your heart and in your brain. An explosion and blockage in the brain is a stroke. In the heart, it's a heart attack. This is why particle size matter. Larger, fluffy LDL particles generally stay in the bloodstream doing their transport job. Small, dense particles are more likely to penetrate the artery walls and cause problems. And this is why inflammation matters so much. The more inflamed your system, the more likely the LDL particles are to become oxidized and trigger an immune response. Let's go over some advanced markers that matter. Apolipoprotein B, or ApoB. It's a better marker than LDL-C because it measures the actual numbers of atherogenic particles in your blood, the particles that can cause plaque buildup. LDL-C, C stands for calculation. So they're making a calculation based on your other numbers. About 25% of the population has a discordance between their LDL-C and their ApoB. Your standard LDL might look fine, but your ApoB could be elevated, or vice versa. Target less than 80 lowers your risk significantly. If you have a family history of high cholesterol, if imaging shows issues, or if you're on statins, sometimes the goal might be even lower. This is a conversation to have with your doctor about how you need to get there. Apolipoprotein A. This is a genetic marker, and you only needed to get it once in your lifetime. About 20% of the population has elevated LP little a, and it's an independent risk factor for cardiovascular disease. There are different tests with different ranges depending on the lab, but what matters is knowing if yours is elevated so you can discuss more aggressive prevention strategies with your doctor. HSCRP, high sensitivity C reactive protein. This measures inflammation in the body. Inflammation is what makes LDL particles more likely to get oxidized and stuck in your artery walls, creating that schmutz that Dr. Henry described. Your target is under 1 for optimal cardiovascular health. What drives an HSCRP up? Chronic stress, poor sleep, blood sugar dysregulation, gut issues, excess body fat, all things that get worse during perimenopause. Uric acid. This reflects your metabolic health, inflammation, and kidney function. Optimally, you want to be at 5.5 or less. If you're above 7, there could be some concerns to watch. It is particularly sensitive to fructose consumption. If your uric acid level is elevated, take a hard look at sweetened beverages, juice, and alcohol. You might hear a test called a CAC scan or a coronary artery calcium test. This can also give you a picture of how much calcified plaque you have in your arteries relative to your age. Women in their 40s typically don't have much calcified plaque yet. It's mostly soft plaque at this stage because they still have that protective estrogen. Usually, doctors wait until mid 50s to see what is calcified because that catch up phenomenon is after the hormonal drop. If you're at higher risk, your doctor might order a CT angiogram with dye to get a more detailed picture. There's also a carotid ultrasound, which is low risk and has no radiation, but doesn't usually catch any early disease. I'm not going to go deep into these tests because, as much as I want to help you build a good foundation, if these imaging tests come back showing significant plaque, you probably need medication to manage your risk, and that's outside of my scope as a nutritionist. What I can do is help you track your labs so that you catch problems early before you need advanced imaging. Let's talk about medication for a minute because I know many of you are terrified of statins. First, let me be clear. I cannot prescribe medication, but I can tell you that there are options besides statins, and medication isn't the failure that many women think that it is. The important thing here is to weigh the risk of heart disease against your options. If you need to lower your cholesterol, there's huge variability in how people respond to dietary changes, particularly saturated fat reduction. Some people see a change, some people don't, and many women replace saturated fat with carbs, which isn't always a great trade off for metabolic health. Medication options besides or in addition to statins. So there's omega 3s, which can provide a moderate lowering of triglycerides. They're not great at lowering LDL, but they can be used in combination with other supports. Red yeast rice. This is actually what statins are based on. Taking red yeast rice is essentially like taking a low dose statin. Zetia blocks absorption of cholesterol in your gut. It helps the recycling mechanism your body uses. It doesn't work as well solo, and for some people, it doesn't work well at all, but it has very low side effects. You need to track your liver enzymes, try it for 3 months, and it can be used in combination with low dose statins to help minimize statin side effects. PSK9 inhibitors, these are newer medications that block the breakdown of LDL receptors in the liver. This means that more of the cholesterol that those HDL dump trucks bring back can actually be recycled and cleared. These are typically used for people with very high cholesterol and genetic conditions, but they're another option in the toolbox. Now about statins. High dose statins are more likely to cause side effects, but that doesn't necessarily mean that they will. Everyone responds differently. If you do need a statin, starting at a lower dose in combination with something like Azedia might be an option to discuss with your doctor. The important thing is that you have to check your labs again after you're starting any intervention, whether it's a lifestyle change or a medication, to make sure it's working. Give it 3 months, test again. Here's my honest take. Most of us will need medications in our lifetime. And it's very hard to be medication free when we're living as long as we do in our modern lifestyle. What I'm advocating for is this: don't wait until you have disease. We can know your metrics and support them early so you don't get the disease in the first place. And if you do need medication eventually, we'll be starting from a much stronger foundation. Now, before we get into exactly what labs to request, I need to talk about something that isn't a lab test, but is just as critical: mammograms. I usually talk only about things that I can directly support. Lab values I can help you improve. But breast health screening is outside of my scope, and that's exactly why I want to emphasize it. Here's the statistic that we just shared earlier. You are 13 times more likely to die of metabolic disease than breast cancer. That's not me saying breast cancer doesn't matter. That's me saying that both matter, and we need to be proactive about both. In preparing for this episode, I talked with a mammographer, Julie Dingy. She's incredibly passionate about women's health, and I love the way she talks about how her work changes lives. Here's what Julie wants every woman to know: you need to get a mammogram every single year, not every 2 years, every year. Why? Because there are many different types of breast cancer and they all grow at different rates. 2 years is too much time to let something grow undetected. Some breast cancers are slow growing and others are more aggressive. You don't know which type you might develop, so annual screenings give you the best chance of catching something early. And if you don't have health insurance or your insurance doesn't cover mammograms, there are grants and organizations in almost every state that can help cover the cost. Don't let cost be a barrier. So, yes, optimize your metabolic health with labs, but also schedule that mammogram. Both screenings save lives. Here's your metabolic health panel to request from your primary care provider. Don't worry, this will be in the show notes. Core metabolic markers, metabolic panel. This is covering your kidney, liver function, electrolyte balance, and your baseline glucose. A fasting insulin. Like we talked about, you need to specifically request this, but it's worth the pushback. Hemoglobin A1C. A complete lipid panel, which should include your total cholesterol, LDL, HDL, and triglycerides. There are more advanced panels if you have the option with your doctor. ApoB. Specifically request this one. LP little a. This is a one-time test that you will also have to specifically request. Your HSCRP, which is looking at inflammation, and uric acid. Lab prep. Go in the morning fasted, nothing but water for 12 hours. Skip your morning workout that morning. Stop biotin if you're taking it 2 weeks before and stay normally hydrated. You don't want to overhydrate or underhydrate. Try to stay right in that sweet spot. Let me tell you about Erica. She'd been diagnosed with PCOS, put on birth control, and medications to lower her blood sugar. Her labs were normal by standard measures, but she really felt terrible. After 3 months working together, we then redid her 3-month labs. Fasting glucose improved by 4%. Her hemoglobin A1C corrected and was moving in the right direction. Her triglycerides dropped by 34%, and her triglyceride HDL ratio improved by 27%. She's no longer on that trajectory towards diabetes and heart disease. She changed the patterns before it became a crisis. And here's the truth: it's much easier to prevent metabolic disease than to treat it. Ages 40 to 48 are metabolically vulnerable years for women. This is when everything can shift, but it doesn't have to be a crisis. When you know your metrics early and track them often, you can see the pattern shift before it becomes a disease. A year from now, one of two things will be true: you're still in the dark, still wondering why your body isn't responding, still waiting for someone to connect the dots, or you finally understand what your body is trying to tell you. You have your baseline, you're tracking your patterns, and you have a plan. The difference: one decision right now. In the next episode, we're going to cover thyroid function, nutrient deficiencies, inflammatory markers, and how to look for patterns across your results. Download the free lab guide in the show notes. You deserve answers, not dismissals. I'll see you next Wednesday.
Can you do me a favor? If this was helpful, share it with one person who might need to hear it today. Our bodies didn't come with a user manual, and this perimenopause thing can feel confusing and lonely. But you're not alone, you're not crazy, and you're definitely not broken. And maybe someone in your life needs that reminder too. Let's spread the word and be kind to each other and ourselves. Now the legal bit. I'm a nutritionist, but I'm not your nutritionist. This podcast is for information and education only. No client relationship was formed. Always seek medical advice when necessary. I'll see you next Wednesday morning.